Good afternoon, everyone. And thank you for joining us today. This is the 5th in our masterclass series, and we are very happy to have you with us. As you know, today's session is part of a series of masterclasses that feature the faculty experts at Rockefeller College. This series is part of the year-long celebration of the college's 75th anniversary. Today's discussion will be led by Professor Patty Strach. Before I hand the platform over to Professor Strach, I just want to make a few notes. You are welcome to start posting your questions for Professor Strach at any point. You can use the chat function. And if you would like for your question to remain anonymous, you are welcome to send these questions directly to me, and then I will relay them when the Q&A session begins. We've enabled closed captioning for anyone who would like to take advantage of that. The transcript can be found in the chat function or on the bottom of your screen, depending on your version. And I wanted to also let everyone know that the entirety of today's discussion is going to be recorded and shared through the Rockefeller College YouTube channel. And with that, I would like to welcome Professor Strach, from whom I'm very eager to learn.
Thank you so much, Julie. I am going to put up some slides. All right, does that work? Can you all see the presentation? Fantastic. Thank you. I'm excited to talk to you today. This is a project I've been working on since 2017. And I've really been down in New York State, across the state, talking to folks on the front lines of the opioid epidemic, really trying to answer two pretty basic questions. What does the problem look like? What does the opioid epidemic look like in New York State, inside New York's many different kinds of communities? And why is it so hard to turn the corner on this problem? The overdose death rates are the highest they have ever been in the history of the United States. So trying to figure out what the problem looks like and why it's so difficult to get a handle on it. And now we're moving forward from kind of describing what the problem looks like to thinking about what we've learned about the opioid epidemic and what we can learn based on existing research. And we are interested in one particular concept, which is the idea of administrative burdens. And we think that administrative burdens can really help us understand the opioid epidemic. And administrative burdens is an individual's experience of policy implementation as onerous. And I'm sure many of you, even if you don't use the words administrative burdens, know exactly what this feels like when you try to do something and it's very difficult, right? So I have those peeling license plates on my car, and I tried to get the license plates replaced, and it required printing off forms and sending in checks, and I did all of that, and then it got returned to me, and with a bunch of other requirements that I was supposed to do, right? So trying to get a service that seems like it should be easy, for which I am eligible, but having to jump through a bunch of hoops. Now, one of the things about the literature on administrative burdens is it focuses on clients, and it focuses on burdens that are placed on clients. And it says, when we place these burdens on clients, they experience policy implementation as onerous, and it reduces access to services for people who are claiming those benefits from public agencies, right? So one of the examples in higher education is because applying for financial aid is so difficult and so time consuming, people who are eligible for financial aid sometimes forego it just because the burdens are so high. But we know less about burdens that are placed not on the clients, not on the end users, but on the people who are providing services. And so our question is, what effect do administrative burdens that are placed on service providers have on clients' experience of programs? So what happens not just when we put burdens on clients, which we do, but we also put burdens on people serving clients? What effect does that have on those clients, on how they experience programs? So I'm going to give you a little bit of background about burdens. Administrative burdens, as I've explained, it's the experience of policy implementation as onerous. And the idea that policy and public administration are difficult and problematic and hard is not a new concept. What makes administrative burdens different is it focus on the experiences of clients. So it's not just me looking at a policy saying, this is something that's difficult, this is something that's not, this is something problematic, this is something that's not. It's talking to people who actually experience those policies and asking them what they think is difficult. And the literature talks about a couple of different kinds of costs that are involved, the cost of finding out programs, the cost of actually trying to engage in programs, and the psychological costs of programs. And one thing that we know about these burdens is that they're not distributed evenly. So not every program is equally burdensome. And what's really problematic is we tend to put the most burdens on those people who are the least able to navigate those burdens, either because they don't have the resources they need, they don't have the time, they don't have the money, they don't have the network or the existing knowledge about how to work through those burdens. And so because of that, it makes inequality even worse, because we put burdens in particular kinds of programs, especially those serving low-income Americans, especially those serving people that we think don't make good decisions. And in this case, that would be people who use drugs. We put a lot of burdens in those programs, and it makes things worse because those people who are least able to navigate those burdens are experiencing most of them. Burdens are distinct from barriers, and a barrier is an objective state action. So where we think about a burden is like the subjective experience, how I experience a program. A barrier would be more of that objective. We're going to look at this. We're going to say it's a problem. We're going to say it makes things more difficult. Those are the rules and regulations. Now, there's a big and growing literature, including by people in Rockefeller College, on administrative burdens. As I mentioned, most of the literature looks at burdens on clients of programs, and it says, wow, when we put burdens on people, it reduces their participation in a host of different kinds of programs. And it also looks at, if we want to increase participation, what are the kinds of solutions that we need to put in place? And usually they find, wow, if you reduce the burdens on clients, you get more people to participate. Right. So that might be things like giving people more information, simplifying procedures, like reducing the number of hoops, not charging people an application fee for a program you want them to participate in. Right. So reducing burdens on clients increases participations in programs. Now, there's very little literature about administrators, and especially very little on third-party administrators. So we don't really have a sense of what kind of burdens we're placing on the people who are supposed to be administering programs for clients. And that we call those people, those third-party administrators, the submerged state, right? These are people who are doing work for the state, but we don't always see them as part of the state. And so these third parties play an important role in policy administration. They work on behalf of the state. They have to follow the rules set by the state. And their job is to serve a public purpose, right? Something that the state wants, but it's going to ask these third parties to actually carry it out. And one of the problems is that it makes government invisible, right? We don't see burdens. We see, if we see these burdens, we see them as being created or caused by these third parties, these submerged state actors, and not as something that comes from government and gets placed on them, right? So we don't see the role of government. It kind of hides what government is doing, and we call that the submerged state. And we're going to talk about how that's problematic in the case of drug policy. So we build our data. We did interviews with 92 substance use disorder service providers and 15 clients. We had a participant observation at 15 sites. We did focus groups with 74 providers and 7 clients. So we have a robust source of data. And there we are down at the bottom in Sullivan County talking to folks. And to analyze these data, we recorded data, we uploaded it to a qualitative analysis software. and we coded what both service providers and clients found burdensome. We do this in the case of substance use disorder services in New York State. And this is a really interesting case because services in the United States, substance use disorder services, are overwhelmingly provided by third parties. And it's the same in New York State, disproportionately, like 90% provided by third parties. So these third-party organizations are very clear on what they're doing, but it's not so clear to the general public, and it's not always so clear to clients where these burdens are coming from and how services are being paid for and provided. All right, so we're going to tell you a little bit about the results that we have. Here's a summary. And really what we find is there's two kinds of burdens. There's direct burdens on clients. Those are things that, the government has particular kinds of requirements. It makes things difficult. It makes it more difficult for clients to access services. They're very aware that this is kind of a policy that's put in place. But there's also what we call indirect burdens, right? And those are burdens that are placed on providers. So that's that first column, it's direct on providers. And then they trickle down and become burdens on clients, right? So putting a burden on a provider, right? Requiring them, for example, to have certain staffing levels when it's really difficult to find and pay for staff means that they have to reduce their hours. And when they do, that becomes a burden on client because it's harder for them to access services. So there's two kinds of burdens, direct and indirect. And the literature overwhelmingly looks at direct burdens on clients. And you can see that's that far right column. And those burdens are significant and they are serious, and there's a lot of people working to change those. And we're not saying that's a bad thing. But what we are saying is far more often, we put burdens on providers and those burdens trickle down to become burdens on clients. All right, so then let's talk about that first one, the direct burdens on clients. And those burdens are in treatment protocols. So accessing substance use disorder services is very difficult. The federal government has a number of rules and regulations which make it really difficult to get the kinds of services that people need. And when we talk about services, one thing we can talk about is medication-assisted treatment. This is kind of a very standard way to treat substance use disorder, especially when we're thinking about opioids. And the two main drugs to treat that are methadone, which is considered a Schedule II drug. So the federal government has a schedule of drugs, and the higher on the schedule, the more tightly they're regulated. Buprenorphine is a Schedule III drug. The federal government also has a number of requirements for people who are seeking services. So they have to have a physical exam before they receive medication-assisted treatment. They have to have frequent screenings, drug toxicology screenings, 8 times a year for methadone or more. And that can be layered on top of, if it's court-mandated treatment, it could be even more screenings than that. And then to get methadone and to receive methadone, that has to be done in person. And in person means that that an individual, certainly at the beginning when they first get diagnosed or they first get treated, has to go 6 days a week to receive methadone, which is quite a lot. All right, so these direct burdens mean that there is just too few facility and too difficult to get to those facilities. And so here we are. Here's one person we talked to said, my daughter is now in a methadone program. It's all the way over there in Newburgh. It's a 130-mile round trip drive to receive a tiny cup of liquid of methadone. That's every day, 6 days a week with a take-home dose for Sundays. So you can see how that would be incredibly burdensome on people trying to receive. You can imagine if every day you had to take a daily medication, you had to drive 130 miles, how difficult that would be. And then a treatment provider says there's still 50 or 60 people that are driving 30 or 40 miles every day to get the medication. Right. So the fact that it's so tightly restricted that we treat this medication as something really difficult to get means that it's very hard for people to access. And it's the same kind of thing when we think about these frequent screening and toxicologies, right? So the frequent drug screenings. And some of the providers we talked to said there's really not a huge difference between testing people, right, through their fluids and what they'll self-report doing. And they say, but we spend more on toxicology than we do on treatments, right? And that this is not done. And a lot of them said, I don't change what I do based upon the results of the toxicology screening. I do it because I have to do it. And it really feels like a punitive tool instead of a clinical one that's meant to help people. Some clients found drug testing helpful, right, to keep them on track and to reward them for their good behavior. But a lot of them felt that it was used punitively to remove them for treatment. Now, all of this trickled to these, very tight regulations that make it really difficult to access services direct on clients means that it's really hard for people to get services. So here's somebody saying I was in active use and I'm calling and begging for help. And they're saying, oh, well, call back in a week or two. That week or two, I might not have made it, right? So it can be really hard for people to access treatment. Another kind, so that is the direct, when we think about direct, but there's also indirect burdens that are placed on, right? They're direct on service providers, and then they trickle down and they're indirect on clients, but they're just as real as those direct burdens I just talked about. So one of the things in substance use disorder services is that people who provide these services, people who provide medication-assisted treatment, have to be licensed, right? So there's, federal law that has what the requirements are, and it requires doctors and medical personnel to do extra training. And even after they do this extra training, there's a limited number of patients that they can see. So the license only allows them to see a certain number of patients. And so this becomes a real burden on providers. It's very time consuming to do this training. It doesn't allow you unlimited access. You still have a limited number of patients that you can see. And so the providers are saying, like, if you actually wanted to treat people, why would you ever have this kind of requirement? It creates this burden, it creates this barrier that just makes fewer doctors, nurses want to do the training, actually do the training. And then, you have a crisis. There's a 2 million person shortage in terms of the workforce for substance use disorder services. This only makes it worse. And then the, lack of doctors trickles down to clients, right? And so this is a quote by one of the moms we talked to, and she said, there's no doctor in my community. The doctor's over an hour away. My son, the person who has a substance use disorder, has no way to get there. So who has to take him? Me. I have to drive him an hour so he can get his prescription and then come back another hour. All the rules that he has to go through to get medication to survive. And the doctors were only allowed to have 150 patients because there was a limit, right? So she's angry about having to drive that far to see a doctor because other doctors can't have more patients. One of the big things that came up is the issue of staffing, right? So again, there's not enough staff. We are 2 million people short in terms of actually being able to staff an SUD workforce that can meet the needs of the people who need to access services. But the rules and requirements in place, this time staffing requirements set by the state of New York, makes it more difficult for providers to staff their facilities, right? So there's certain very specific staffing requirements by type of service provider. So whether you're providing inpatient or outpatient, there are different levels of staffing that you need to have. There's also limits on how much providers can pay staff, right? So the state pays for a lot of these services. And so providers have to say, here's my budget, here's what I'm paying staff. And if a staff member gets another job, they can't just up the salary to retain that staff person. So that staff person might leave. And again, you might think to yourself, wow, we have an opioid epidemic. We have, 100,000 people a year dying from drug overdoses. We have a significant staff shortage. You would think to fix this shortage, you would increase wages and therefore better able to meet staffing requirements. But that's not what happens. Instead, what happens is becomes a very big burden on providers. It's very inflexible, right? So we're paying for salaries, even though we think we have to have a particular kind of employee, even though it might be better to have another qualified employee in that spot. And so a CASAC is a certified alcohol and substance abuse counselor. Right. So, and then here's this, you have requirements by state agency to have a CASAC, a counselor, and then you cannot find a counselor to fill this position. Right. And if you can't find the counselors, if you can't find the staffing, you have to reduce the number of people that you bring into your facility or reduce the number of hours that you see people. And so here's somebody talking about what it's like to get somebody into services. You're trying to call for a bed. There's not a nurse there. There's not a doctor there. So you finally press every button that you can to talk to someone and they say, oh, well, no, the nurse isn't here. She'll be in on Saturday. And when you're trying to get people help, that's not a very helpful thing. Okay, but you can see how it trickles down, and this burden, a staffing burden, becomes a burden for clients. Funding is also a problem. So the state of New York has a deficit funding model, which means that providers go out and get whatever funding they can get, and then the state will provide the last dollars to provide services. And the deficit funding model means that if a provider goes out and, they have more clients with private insurance and they're able to bill private insurance, if they get more grants, the state doesn't let them keep that model or innovate that money or innovate with that money. Instead, the state takes its money back. So they get penalized for going out and getting more sources of revenue. Another problem is reimbursement. And so the state reimburses based on kind of these units of time on 30, 60, or 90 minutes. And so you may have a client who needs a lot of time, a lot of care, but you don't have the ability to charge for that care. Or you may have a client who needs very little care and you have to fit them into one of these kinds of boxes. So again, this is a burden on providers, right? They can't pay what they want to pay, that it stifles innovation, right? So one of them says, if we exceed our performance, the first instinct on the part of the state is to take some of that money that let us do that. There's no other business that would work that way, right? And this trickles down to clients in terms of limited services. Right. And so there's somebody who's told us, if I'm not going to be funded for navigating somebody, that means getting that person, the person might be leaving my facility and they need to have a certain kind of transition to another type of facility, but I don't get funded for that. I don't care about it. And that's a big problem, right? Because we're not thinking about what's the best way to get this person into that next level of service. We're thinking about what's being paid for. And if it's not being paid for, it's not being done. There's barriers on facilities, which I'm going to skip over. And I'm just going to talk a little bit about the implications for researchers of this study. And that is that clients experience two types of burdens. They have the direct burdens on them, right? Those are the things like the drug testing they have to go through, and they have to, come in 6 days a week for their medication. But they also experience indirect burdens. They experience, the burdens that are placed on providers in terms of staffing and funding, trickle down and become burdens on clients that make it hard for clients to access services. And, for researchers studying one type of burden, direct burden, you can imagine you're missing most of the kinds of burdens that clients are experiencing. And you're not able to provide a full descriptive picture of kind of the total burdens that clients experience. And you're also not able to understand the types of policy interventions that clients need, that we need to make this problem better, right? It isn't a matter of education. That's the number one go-to in SUD services. We'll just educate people. We'll just tell them what they need. It's not education that they need, right? They need extended hours. They need ability to access treatment when they show up and they ask for it. And it also, because this is doubly hidden, right? So on the one hand, these are indirect burdens. So we're not seeing them as something that's directly placed on a client. And the second thing is they're coming through these third-party providers. So for a lot of people, and especially the clients we talk to, most of them did not associate the burdens they were experiencing with government. The providers 100% did associate these burdens with government and were very aware of what the rules and regulations were that were causing them this increased difficulty, these barriers that they had to jump over. But because this is kind of like stretched out and hidden, it really prevents individuals, clients, and just individuals in general from holding government officials accountable, because we don't necessarily think about this as being a government's problem, or that this is government that's causing these burdens. It's too easy to look at the providers and say that they're the ones that are creating these difficult situations. There's also policy implications, and that can be that, because this is doubly hidden, it's indirect, and it's through these third parties, it can be really hard to see these burdens, right? And it can all too easy to look and to say, if clients aren't accessing services, it's because they don't want to, or they're not trying. Or if they tell me they're having a hard time, and we've heard this a lot, it's because they're lying, because those services are there, they're available, we're paying for those services. There's no reason they can't access them, right? So, if you're looking at one tiny slice, it's very easy to see that all of these other things that government is doing, that government is putting on, it's creating burdens for clients. And so the other policy implication is that, if we want to make this problem better, if we want to make services available for people, we have to reduce the overall policy burdens in this area, both on providers and on clients. Otherwise, it just slides all the way down to the bottom and affects clients. So in conclusion, what we've learned from this study is that burdens are both direct and indirect, right? So they both affect clients directly, and they affect these third-party service providers and trickle down to clients. So if we want to understand the true size of burdens in an area and on clients, we have to take both of those into account. If we want to think about what kind of policy interventions need to be in place to be effective, those kinds of things I talked about at the beginning aren't really the answers. Instead, we really have, they're part of the answer, but it's just a small slice. We can't just provide more information or reduce the cost. We also have to think about increasing hours and increasing staffing so that people can actually access service. And then the last kind of implication is one for democratic accountability, that it's hard to hold government officials accountable for problems that we don't trace back to government policies. Thank you so much. I look forward to taking your questions.
Thank you, Patty. I think I would just be inclined to let you manage what you're seeing in the chat. But I just want to remind everyone that if you want to send me a question, I'm happy to pose it anonymously.
Okay, great. So let's see. The first question is, based on what I've learned, how does outright lack of capacity squarely within state contribute to the creation of administrative burdens? To put this in the other way, is the problem how the state relates to third-party providers, or perhaps the third-party providers aren't necessarily aligned with the actual goals the state is seeking to achieve? So one of the things about third-party providers is that we see them across a range of policies, but we see them kind of in terms of the burdens, disproportionately in burdens that help people who are low income or stigmatized. There's a lot of burdens, and there's a lot of policies that are being administered by third parties. And so the problem is that I don't know if policymakers don't see, for example, the relationship between the burdens that they're putting on providers and the outcomes for clients. I think what we see instead is very frequently that that policy officials will look at the data and not connect, here's all our rules and regulations, here's the effect that it's having on clients, and instead say what they're looking at is saying there's no reason that people can't access services. And in the state of New York has been really good on a number of fronts. New York pays for treatment for anybody who wants it, regardless of insurance. The state of New York has fought to get rid of pre-authorization, so private insurance companies can't turn people away, that they can't automatically kick people out of treatment once it reaches a certain number of days. So the state has been really good, but it's been really good at addressing things that other actors are doing and not really good at addressing things that the state itself creates and maintains that make it difficult. So I think that's what I would say, that it's I think these third-party providers are out there and they're trying to provide services, but they're providing services to a group that is not considered loved, and that the state does not want to spend a lot of money on. And so you get these policies which are punitive and difficult, and it makes their jobs a lot harder. What is the most surprising thing you found in your data gathering? I think I found a lot of things that were surprising. I don't know if there's one thing in particular that was most surprising. Maybe the disconnect. I think one of the things that was really striking is, on the ground, the message is so consistent in terms of what folks are saying. They're telling us, I can't get into treatment. I can't get into treatment. I can't get into treatment. These nonprofits are saying, I'm trying to get my clients into treatment. They're getting turned away, kind of running through over and over again. It's like 100% consistent. And then when we talk to policy officials, it was like it was an entirely different problem, right? There's no reason people can't get into treatment. People are lying. People who use drugs lie. There's empty beds. There's no reason they can't access those beds. And so a lot of it was trying to figure out this puzzle that why would policy officials see such a different picture than people who are accessing services and people working in the nonprofits and in the medical establishment trying to get people into services? Why are they having such different experiences? And so that's really what we were surprised to find, and kind of what sent us down this path. All right, next question. Oh, things are moving. I have to scroll. Okay. How deliberate do you think these burdens are, or are they more inadvertent? That's a great question. Are burdens deliberate? I do think, and this comes from, Schneider and Ingram wrote an article about social construction of target populations, and they say, well, the distribution of burdens is in no way random, that we put the greatest burdens on people who are the most negatively constructed. We put the greatest burdens on people that we think don't know how to take care of themselves. They're perfectly fine people, but they're not very good about making decisions, or that we think, they're morally bad people. And so we have to step in and really decide for them how to live their lives. So we put the most burdens on those people that we kind of share an understanding of that is negative. And the literature, the example they use in terms of one of the groups that's the most negatively constructed is that people who use drugs. And so the burdens on these people, it's politicians trying to say, look, if I do something for drug users, I'm going to get slammed in, by my colleagues and in an election. If I do something good for people who are in prison, I'm going to get penalized in it in the next election. And so they're reinforced, even if they want to, they may reinforce that. So I think there is so I think in general, we put burdens on these populations. And I think drug users are one population that get disproportionately gets that. Now, is it inadvertent? Well, the federal burdens are coming from our drug policy. The treatment regulation is overseen by the Drug Enforcement Agency, which is a law enforcement agency not known for being soft and fuzzy and kind. So I think putting treatment, which is supposed to be healthcare, in a law enforcement agency means it's going to look a particular way, and it is going to be more punitive. But I also think that policymakers, they don't really have a desire to sit there and think through what ways that they could make it easier for people to provide, for the state to provide services through these third-party providers. All right, so here's another question. It says, based on what you learned, how can your research be used to address other services such as behavioral health services? That's a great question. I work at Rockefeller College. I'm the director of the undergraduate program. And when I took over that job, I said, we need to think about reducing administrative burdens. We need to think less about, the temptation is always to create new services, to create new programs. But really, I think across the board, in whatever kind of organization you're in, thinking about how to get rid of things, not adding new things, but what can you get rid of that makes it easier to access and provide services. And I think with behavioral health services, you have a lot of the same problems that you do in substance use disorder services in particular, right? So it's kind of a larger area of the same kinds of issues. There are staffing shortages. There's a lack of availability of services. There's very long waits to access these same kinds of services. And if there is a commitment to these services, one, we have to think about funding them in such a way that people will work in those services and provide those services. And we also have to think about the kind of environment in terms of burdens that we're doing that make people want to leave those kinds of jobs or not go into them in the first place, right? So you have to be really dedicated to provide substance use disorder services, because a lot of times it isn't very easy work. It's not well compensated. And it's incredibly bureaucratic. And so if we think about reducing burdens, I think there's a lot of lessons in terms of the burdens we put on people. And there is a fine line, because some of these burdens really are about keeping people safe and keeping people healthy. So you don't want to reduce all burdens, but you do want to think about which burdens are necessary to keep people safe and healthy, and which ones are there preventing people from being safe and healthy. Right? That we have so many rules that people who could have received help didn't get it. Thank you. Are there other questions I can answer?
This isn't quite a question, but it seems like there might be some connection with the work that you've been doing and models that emphasize harm reduction, but I can't quite see what that connection might usefully be.
Yeah, so harm reduction is the principle, right? It's the principle that to best treat people, we should alleviate the harms that are being done to them. So the goal isn't to get people to stop using drugs. The goal is to reduce all of the harms associated with drug use, so that when somebody's ready to stop, they're still alive and they can access services. So harm reduction is a philosophy. It's moved into New York City, and now we have a director of the Office of Addiction Services and Supports who is from the harm reduction community. So harm reduction would be things like needle exchanges. They want safe injection sites. They want strips to test drugs, right? So that, I think there's a real sense that we can just let people who use drugs overdose, and then that's on them. But people who are using drugs aren't using drugs to overdose. They're not using drugs to get other kinds of diseases, like through a dirty needle, get Hep C. That they do care about their health. They do care about living a healthy and good life. But sometimes they aren't ready to receive help. And sometimes, you can use drugs for a very long time and be very, have a very productive life. So harm reduction is just kind of that philosophy that if you keep people alive and you keep them healthy, and you don't judge them, and you provide them kind of food and socks and the kinds of things, clean water, the kinds of things they need, that when they're ready to receive help, they will get help. So it's related in the sense that we're thinking about why is it so difficult to get the kinds of services that people need. Harm reduction is going to focus on like, why do we make it so difficult? Why do we make people get clean when they're not ready to? Otherwise, they can't do anything. They can't get into housing, stable housing. They can't get, other kinds of medical care, et cetera, et cetera. So they're definitely related. And I think the folks in the harm reduction world, would say no testing, no, tons of requirements that we put on people, that we make it difficult for people to get what they need. So that part is very much shared in terms of reduce the burdens that we put on people so that they can get what they need.
What do you see as the trade-offs between doing this kind of work as kind of a top-down state imposed set of programs versus putting more of it on local organizations, local sites of government and governance? Because I could see an argument kind of going in either direction if we are centering trying to reduce administrative burdens. Because one could say, all right, at the state level, you can do something comprehensive. You can kind of command and control and say, here are the things that you can't do, here are the resources that have to be available. But it sounds like from a lot of what you're saying, it's the local people who are actually working directly with people who are struggling with substance abuse, who understand what the administrative burdens are.
Yeah, I think there's a couple ways to think about that question. So the state sets all of the parameters for what these third-party providers do and how they do it. And so one of the interesting things is I pulled the rule book that they have to follow in terms of guidance and advice, and it's like a 55-page document. And that these third-party providers are following the exact same rules that I have to follow when I travel as a state employee. So they're putting a lot of the exact same rules on folks that would be put on state employees. But unlike state employees, these third-party providers don't have the same kinds of resources. They don't get paid at the same level, right? So you might make $15 an hour as a counselor. And if you work for the state of New York, the state workers are unionized, you're going to make a lot more than that. You're going to have a retirement system. You are going to have far more resources, right? And so one of the things that these providers were saying is you're asking us to do the work of the state without the resources of the state, right? And following all of these very specific rules set by the state. So there are, there is this trade-off, and then you put these, one of the other things happens, the state doesn't pass a budget, or the state doesn't get money out. And when you work for the state, your lights usually still stay on and your office usually still stays heated, but they don't have that luxury when the state comes in and the dollars are late. And so they have to go through all of the process of arranging a contract, having a budget approved, et cetera, with the state without any of the resources. And so I think there's significant variation across New York State in terms of what is happening in local communities, and significant variation with these service providers in terms of what they have the capacity and resources to provide, right? So in some communities, there's just nothing. There's nothing to build on. There's nothing that's already there. The local government is already overtaxed. They might have one or two people working in the health office at the county level. And in other governments like New York City, they have a very established infrastructure, right? And so in one place, the feeling is the state is holding us back because they don't understand what it's like to live in an under-resourced rural community. For example, they don't understand that we can't meet these requirements, right? The state has all of these things in terms of competitive bidding. So if you want an extra grant, you have to apply for it. And some of these communities, not just the service providers within them, don't meet the minimum threshold. If you're not serving an area with 100,000 people, for example, you can't apply. And so some of these areas are less than 100,000 people. So you have that on the one hand, and then you have New York City on the other hand, which is basically pushing the state of New York to move faster, right? It's adopted these policies and programs that the state has yet to adopt, right? So it was the first one with a safe consumption site for using drugs more safely, and pushing the state to make that something that can happen in more places across the state. So you have this huge variation in terms of communities and what they have access to, and you also have variation in service providers. And one of the things that service providers are saying is, I work in 5 different counties. I have to follow the rules, not only of the state, but of these 5 different county governments. And so that adds a layer of complexity, right? So the substance use disorder services straddles state agencies. So you might be providing substance use disorder services and, mental health services. And those are 2 distinct agencies with 2 distinct rules. I didn't talk about it in the presentation, but it was there in terms of like where doors are located and how wide hallways are. And so you may have to like retrofit buildings or kind of meet these 2 very different set of standards. And then you layer on, you have to also meet these different county goals and county requirements. And so what you get is service providers who feel like they're juggling federal, state, local government regulations, and then they also apply for grants and they have to meet what their grant funders want. So unlike a state agency, which the state is your boss, you have all of these different organizations that you are reporting to. They have different data requirements. They have different rules in terms of facilities that you have to follow. And they just describe something that is really inconsistent and incoherent. So would it be nice if the state came down and were to loosen up these rules, or to give flexibility, or to, reduce the reporting burdens? It would be great. But it would have to kind of trickle out to county governments and to other kinds of like federal government, for example, which has a lot of requirements as well, right? So it's just a really, really tightly regulated area, and it makes it very difficult to provide services. And to get back to Victor's question, makes it very difficult. And one of the surprising things is, these people have to be extremely dedicated to provide services because they're not well compensated and they're not treated particularly well. All right, we have 2 questions in the chat. Have you done any comparisons to other programs that have large administrative burdens? If so, are there any examples of changes that have been made to make programs less burdensome and more accessible? So I have not done any comparisons to programs with other large administrative burdens, but there is a literature out there that looks at, the kinds of changes that were made. And sometimes these small changes can have this very large effect. And so one of my favorite studies is done out of the University of Michigan, where a professor there sent letters to eligible high school students and said, if you apply to the University of Michigan, you do not have to apply for financial aid, and this is how much it will cost you per year. And so the number of students who applied went up, and the number of students who got in went up, right? And these are targeting low-income communities who look at the cost of the sticker price of the University in Michigan and say, that's too expensive, I can't afford it. So by moving that forward, so by telling people before they even apply to the school, here's how much it's actually going to cost, take away that mystery, they are more likely to apply. And this was not a new program. This was an existing program at the University of Michigan. All they did was provide that information to eligible high school students, low-income high school students, and then the application and acceptance rates went up for that group of students, went up significantly. So there are lots of different things. Some of these are small tweaks that you can do that can have a quite significant impact. So there is a developed literature. There's not such a developed literature on reducing burdens on service providers. Second question in the chat is, how much of this do you think is about financial resources if we funded these services really well? In other words, how many burdens you've identified would be addressed even if some of these burdensome rules were still in place? That's a great question. If we wanted to solve the opioid epidemic, we would fund services at higher rates. And if we funded services at higher rates, a lot of these burdens would be significantly reduced, because a lot of the burdens come down to things like staffing, that people can't access services because if there's no. This was one of the things that we found. This woman was saying there's this great program and we like to send people to this program, but there's nobody to answer the phone. And so therefore we can't get people into the program, right? And so it can be as simple, not only about a doctor or a nurse or a clinical staff person, but about having someone at the front desk to answer the phone, which allows people to actually access those services. So if we funded better, yes, we would have better access to services, but the flip side of that is that I don't know, and Ashley's on this, maybe she knows better than I do. I don't know of any health policy area that is heavily regulated as drug treatment is. So one of the things that's interesting, Schedule 2, Schedule 3 drugs, if you are prescribing these pain relievers like methadone for pain, the burdens are much smaller. If you are prescribing this for substance use disorder, that's when clients have to come into the facility 6 days a week. So part of the rule baked into the rules is the idea that we can't trust people who are using drugs and who want treatment for that. We can't trust those people. And so we've put in place a lot of burdensome rules that really reflect that this is not healthcare provision. And instead, as I mentioned earlier, in terms of the Drug Enforcement Agency, this is seen as kind of preventing drugs from getting into society, or preventing people from using drugs unnecessarily. It's seen it's seen from the get-go that these people can't be trusted, because if I went in for pain, I wouldn't have a problem. But if I go in for substance use disorder, there's a whole list of things that I have to do to receive the exact same medication. So I think more money would definitely help, but we also have to think about the kinds of rules that we place on people and which of those rules are really necessary and really effective, and which one of those rules are just because we don't like people who use drugs, or we don't trust people who use drugs, or we think there'll be penalties for treating them better than we do.